Thank you, Mr. President. Could I be promoted to King, please? Okay, thank you very much. I'm going to present to you a brand new study on empagliflozin in safety during month of Ramadan. The study has just been published online very recently, and this is my disclosure for the presentation. I'm grateful for BI for supporting this session and the conference. Don't want to bore you. You all know this. You're in a dark conference. You know how many people fast, and the prevalence of Muslims globally is 24% of the global population. If you were to look into the previous risk calculator, which we had, you would obviously familiar with the scoring grades. But SGLT2 inhibitors, as one of the types of therapy, were not featuring on the score because we didn't really consider them to be part of a problem, but partly because we didn't have enough information at the time of publishing the guidelines 5 years ago. You will soon, inshallah, in the next sessions of today, you will see the new risk calculator and you will see whether that has changed or not. So this is the study that we have just published, as you can see here, just this month in the Journal of Diabetes Endocrinology Practice. And I'm very thankful for all the co-authors who took part in this data. This is a sub-analysis of the DAR Global Survey. And obviously, you all know that in guidelines, we want people to understand that the vast majority of people want to fast, and we need to provide them with tailored treatment as part of the structured education. And as I mentioned, previous studies on SGLT2 inhibitors, in the beginning, in 2016, when they were launched, one of the guidelines said, do not initiate in Ramadan. And obviously, do not initiate in Ramadan means I cannot prescribe it for 10 months or 9 months and then stop and then start. That obviously is impossible. Luckily, with the first study on SGLT2 inhibitors was in Malaysia, and then other studies followed, mostly in hot and humid countries, and it did not show us a problem. This is, as I mentioned, is a sub-analysis of the DAR Global Survey, which took part over 2020 and 2022, and the global survey was from Morocco west to Indonesia east, with 5 different sub-regions. We took the people who were on empagliflozin, compared them to on empagliflozin without sulfonylurea or insulin, with sulfonylurea, or with insulin, or with both. So in the presentation with the color code, you will always see these 4 categories. Category 1 is empagliflozin without SUs or insulin. Category 2 with SU. Category 3 with insulin but without SU. And category 4 or group 4 is with both. Of course, what we really wanted to look into, does the treatment with empagliflozin as an example of an SGLT2 inhibitors, does it affect the rate of fasting and then consequently the outcome of the glycemic outcome, hypo and hyperglycemia, and eventually, of course, the practice of people, the amount of education and self-monitoring of the blood glucose. So the study population included 1,400 persons, and this is the largest SGLT2 inhibitor study, more or less split between men and women, slightly more of men than women, which is the trend that we see in many prescribing of SGLT2 inhibitors. The vast majority of the prescribing was done by my colleague here in the corner, Professor Yaqub Ahmedani in Pakistan. They had the largest proportion of patients on SGLT2 inhibitors in general, empagliflozin, followed by Gulf and then Southeast Asia, and in Maghreb countries, because of reimbursement, it was pretty rare. As you can see, the group 1 was 30%, group 2 with sulfonylurea was 41.8%. Sorry, group 2 was 21.9%. Many people on insulin were also on empagliflozin, 41.8%. And those who are on both sulfonylurea and insulin on top of empagliflozin was only 6% of the group. it does look like we as clinicians, we tend to prescribe empagliflozin early in the disease process, and then we add other therapy as the disease or the age get older. So you would see here the mean age for group 1 is 50.8, and then 50.3.9, 54, and 54, which also reflects on the duration of diabetes from 7.8 years to 9.3, and then 13 years, and then 11.9 years. So clearly, we think of insulin later when maybe the disease has progressed and the requirement for insulin becomes higher. And it does look like we now think of SGLT2 inhibitors before we think of insulin. So thinking of the control of the subgroups, the mean HbA1c in the group 1 was 7.9, group 2, which is the EMP plus SUs, was 8.3, and then on insulin, clearly it's 9 or 8.9. And with a higher proportion of those with an HbA1c less than 7.5 in group 1 compared to the other groups, you can see the trend going down as the disease progresses and as we get older and the treatment becomes more complex. So looking into the other profile of people, whether the blood pressure, the weight, and so forth, the vast majority of people were around the BMI of 29, give and take. The blood pressure was trending to get higher as we get older, and longer duration of diabetes for people on insulin, and the LDL was exactly matching this. I'm glad to see that current smokers, as we progress, so perhaps when we are young, there is more smokers, but as the disease gets longer for duration and we get older, the smoking trends becomes less, which is really important because obviously the cardiovascular risk is higher. Now, people with diabetes, many of them will have problems or other comorbidities. And you can see here the significant change. So hypertension, hyperlipidemia, retinopathy, neuropathy, microalbuminuria, nephropathy, macrovascular disease, and diabetic foot. All of them gets higher as the disease progresses. So when you get on insulin or insulin sulfonylurea, you clearly have much more of these complications. But I also want you to remember that not all people with diabetes have complications. The blue group, which is empagliflozin without sulfonylurea or insulin, 36% of them, their doctors reported no complications. None of these complications was present, and even about 16.8% of those on insulin and empagliflozin did not report, or their doctors did not report having complications. Perhaps, obviously, if we screen more thoroughly, these percentages might change. Now, if you look into the rate of patients on fasting, so how many people on empagliflozin without SU or insulin fasted? 92% with an average fasting days of 28, was not different for those on sulfonylurea, 92.5% with an average of 28.5 days, goes down as we get on insulin. But again, quite interesting, those people that I've mentioned with lots of complications, with longer duration, being on insulin and or SU, 85 to 88% of them are fasting with an average fasting day per month of 27 days plus. So clearly, the vast majority of our patients treated with SGLT2 inhibitors, empagliflozin, with or without insulin sulfonylurea, are able to fast a month. Now, when you look into the complications according to the baseline group, and here you can see that, of course, the rates of complications were higher as we get into sulfonylurea or insulin. The groups would end up with much more complications. And our analysis was not adjusted for complications. So obviously, this is the package of the person being with complications as well as the type of therapy that have influenced the outcome of the data. So looking into the fasting outcomes, well, obviously, you first look into symptomatic hypoglycemia. Symptomatic hypoglycemia, it's different than confirmed hypoglycemia. So in people not on insulin and not on sulfonylurea, we have 6.9%. When you have a sulfonylurea, the trend gets higher. However, that was not statistically significant. What is statistically significant, obviously being on insulin, where it gets nearly triple to 17.4, and that was statistically significant, and definitely having both. So probably it's the effect of the insulin plus the older age plus the longer duration plus the complication rather than just the insulin. It's important to remember this point. Looking into hyperglycemia, the feasting that we have every day, that also interestingly is higher than hypoglycemia. So hypoglycemia was 6.9, but hyperglycemia, which was reported as blood glucose above 300, was 8.4% on those not on insulin or sulfonylurea, 9.8% on sulfonylurea, and still that was not statistically significant. On insulin, it was 13%, and on both insulin and sulfonylurea, that was statistically significant, and that was 22%. With the insulin as well, it was statistically significant. So when you look into the severity of hypoglycemia, it's one thing that I report to my doctor. Did you get symptoms of hypoglycemia? Yes. But how bad was it? And we try to address this by knowing whether people needed to break their fast or get admitted to hospitals. So breaking the fast, you can see clearly, is much higher once people on sulfonylurea and insulin, and needing to, and the education. This is a slight bias because we as doctors were answering the question. So are we going to say we did not provide education? Likely to be not. However, as you can see here, on average, it is 66% to 80% of the people receiving education. Most of it was, when you look into the duration of education, 0 to 15 minutes, which means during the routine consultation rather than a dedicated educational session as it should be. So the lack of education is reflected on the self-monitoring, because we all in the guidelines, all guidelines says we should do blood glucose monitoring more frequent in Ramadan. And for those on sulfonylurea and insulin, the highest risk group and the older and with more complications, only 39% did SMBG more frequently than before Ramadan, which clearly is a gap that we need to address. And I'm sure in the later sessions that we'll have on SM, on blood glucose monitoring, we'll address this. Very recently, my good friend here, Al-Amin Abdul Qadir, did a systematic review and meta-analysis on all the SGLT papers that were published before that. And we have looked into many factors. I'm sorry, it's not very clear on the slide here, but with all the studies on SGLT inhibitors, does it cause ketoacidosis? No. Does it cause hypotension or dehydration? No. Does it cause impaired renal function? No. We do not see any problems. The only thing we see is less hypoglycemia in comparison with the comparator, which is usually SUs, and in our study here, in comparison to sulfonyl to insulin. So my takeaway home messages is empagliflozin in this particular study, without sulfonylurea or insulin, was shown to be having very high rates of tolerability. Very small number of people were not able to fast, and it had the least number of hypo or hyperglycemia, and people were able to tolerate it. Having sulfonylurea added to it increases the trend slightly, although in the majority of parameters was not statistically significant. What is significant, obviously, is having insulin or having both, and that has impacted all of them. And I'm coming to my last slide. And clinical implication of this, obviously, is we need to have more robust evidence with randomized control trial if possible. The systematic reviews are telling to us that it is quite safe to be given. And we have, even in this systematic or meta-analysis, have suggested we do not particularly see a problem in initiating close to Ramadan if the person is very well educated on the symptoms that they might encounter. So thank you, and looking forward to the continuation of the sessions.
Thank you very much.